Everybody, welcome back, and this is going to be the second half of our epibiostats course, now focusing much more on the epidemiology. Now that we have the foundations of biostatistics, it's going to serve us pretty well when we get into more specifically looking at epidemiology in the literature. And so the first lecture here is going to be basic concepts and principles of epidemiology. I won't bore you to death with all of these objectives, but we will hit all of these as we go through this lecture. So first off, as far as definitions go, epidemiology is going to be considered that study of distribution and also the determinants of disease within the human population. So it's saying, looking at the specific population and seeing what are the things that lead them to develop these kind of diseases, right? And so it's going to be a lot of the basics and kind of the fundamentals for public health. So if there's ever something you want to go into, like working for the health department or the CDC, this is kind of the basics of what they use this stuff for. And so it comes from the epidemiology comes from the word epidemic, which also is Greek for upon the people. So kind of makes sense when you're kind of looking at these things. That it really is kind of looking back at a population and looking again for this distribution and determinants of disease. An epidemiologist would just be a scientist that's going to be studying disease frequencies in these populations, and they're trying to look for those risk factors, not only for disease but also for health, right? And ultimately try to improve the health of the population. So a lot of this focuses on things like preventative medicine and whatnot in order to prevent disease from occurring in the first place. And health is a definition, one of which we have from the World Health Organization, is going to be this kind of state of complete physical, mental, and social well-being. And it's not merely, the absence of disease or infirmity, but certainly having kind of all aspects of life being kind of in check, so to speak. And so again, you can look at epidemiology, not just looking at physical ailments, but you can also look at things like, risk distribution of addiction, other kind of mental health issues, and all sorts of things we can look at to see how that's going to be affecting our population. And preventative medicine is just going to be that application of those preventative measures we've kind of determined from looking at some of these epidemiologic studies and applying that to helping to try to maintain health and hopefully prevent disease from occurring in the first place. And obviously public health is just that application of preventative medicine principles to the population, try to keep them healthy as best you can. And so one of the kind of buzzwords you hear a lot in epidemiology is going to be epidemic, and so we'll talk more about the definition of that in a second, but I'm surely you've heard of pandemics before as well, and generally you find epidemics are located or restricted to one location. However, if it's able to spread, say, to other countries or continents and affect a larger number of people, that's when we can kind of term this to be a pandemic. Generally in the context of some sort of infectious agent, things that can help it to trigger an epidemic include things like increased virulence, if you're able to spread the disease more easily, or perhaps if you've introduced into a novel setting where say that the population is being exposed to may not have kind of good host defenses against it. Also, changes in host susceptibility over time to the infectious agent, and then also changes in kind of the host exposure. And keep in mind, epidemics do not need to be actual contagious, say from person to person. So for instance, like the West Nile virus, not necessarily contagious from person to person, but certainly through things like mosquitoes or things like obesity, which obviously is going to be much more of a kind of a genetic / environmental kind of disease state. So again, a lot of it has to do with new rates or changes in rates of disease that leads to kind of what we call an epidemic. So a good example of utilizing epidemiology to kind of characterize some of these diseases would be cholera. Cholera, we know, is an infection usually found in the small intestine caused by this bacterium, the Vibrio cholerae. And so the main symptoms we see associated with this are things like profuse watery diarrhea, some vomiting, and typically what you find is that transmission occurs primarily by drinking water, or if you are eating food that's been contaminated, especially by the feces of, say, an infected person. Including, even if they don't have any kind of apparent symptoms, they can still possibly be spreading disease. And so what you find is if you don't treat this early, or if you have not good facilities or good supportive care, that dehydration and electrolyte imbalances can lead to death in some cases. Now, in order to treat someone with cholera, typically it's going to be supportive care, including things like oral rehydration therapy, to replace water and electrolytes, IV therapy with fluids if they may not be able to tolerate that, and then antibacterials. And we see that worldwide affects many millions of people every year, and has caused anywhere between 100 to 130,000 deaths just as of 2010. And so the reason why I bring this up is because it's actually one of the earliest infections we ever actually studied utilizing some of these kind of more modern epidemiological methods. So nowadays, if we catch it early and treat it appropriately, you can see that mortality is pretty low for cholera. However, if it's untreated, the mortality rate can rise pretty significantly, anywhere between 50 and 60%. And so the reason why this is so important is because, if you don't have kind of the epidemiologic studies to really try to identify these diseases or the test to make the diagnosis, a lot of these things can go untreated for a period of time. And so this is one of the big problems many years ago, back before we even knew really what cholera was or how it spread. It was difficult to identify these patients and actually treat them appropriately, or maybe get rid of the actual vector that was spreading disease in the first place. So we'll talk more about that specific case in a second. But another example would be certain genetic strains. So again, if you have actual change in the variants of cholera, can cause outbreaks. And so, for instance, in 2010, there's an epidemic in Haiti, and there's also another one in 2004 in India. And the death can occur, very quickly for some of these patients, especially depending on comorbid conditions and how well they're taking care of themselves beforehand. But even within 2 hours, right? And so what we see is that, especially primarily in the developing world, many more people are going to be susceptible to this and are much more likely to see more mortality. So using things like epidemiologic studies, it's surmised that cholera has originated in the Indian subcontinent and has, been very prevalent in the Ganges Delta since, time immemorial, essentially. And so, the disease found that it was first spreading, by trade routes, both, both on ground and on the water, to places like Russia, Western Europe, and even to North America. And so, in the past just 200 years, we've seen 7 different cholera pandemics actually occur. The last major one was in 1961 back in Indonesia. And so just due to how devastating this disease can be, this actually became one of the first reportable diseases in the United States. And so you'll find that there are several types of diseases that are considered reportable to the CDC because we are very interested in looking for things like new epidemics or pandemics that are starting up. And so this is one of those kind of the first ones we had that actually were reportable. And so what's interesting is, one of the first kind of modern uses of epidemiology, so to speak, was this physician in England. His name was John Snow, not the same one that's King of the North, but we find that he was actually able to identify kind of this contaminated water source back in 1854. It was this Broad Street pump where a lot of people were getting their water from. And I'll show you a map of that in just a second. It's kind of interesting to see the spread of the disease around this particular pump. But with proper identification and proper sanitation and things like that, cholera nowadays is not really considered kind of a pressing health threat into more developed countries in North America and Europe, just due to the fact that we have things like filtering and chlorination of water. But as I mentioned, in several developing countries, you can see a lot of people being affected by this, and mortality is still a big issue. So here's an example of different water pumps that were found in London at the time when John Snow was actually looking around. And so you can see here that, several, the blue dots are these water pumps, the red dots are these cases of cholera. You can kind of notice, not a whole lot of dots around some of these kind of outlying water pumps, but this one particular one on Broad Street, a ton of different cases that were being developed around here. So again, this guy, John Snow, is actually going around and, questioning people and trying to determine where people are living. And again, what they found was this common water source amongst all these different people. And once they're able to clean that and get it decontaminated, then all of a sudden you saw a big drop off. And so again, these are the things that the kind of epidemiologic studies that we can do to actually really have a concrete improvement on people's health in general. Another good example of this is called childbed fever. This is this puerperal fever, and it is caused by bacteria. And typically, it was contracted by these women that were either during childbirth or during miscarriage. And so it can develop into this kind of sepsis, which is oftentimes fatal. And so basically from the 1600s up through the 1800s, majority of childbed fever cases basically were being caused by the doctors themselves, unbeknownst to them. And this was before we really had major knowledge of things like germs. And at the time, they just didn't really believe in hand washing being a very kind of necessary part of their normal care. Obviously, we know nowadays that this is really kind of a bad idea. But what's interesting is they were looking at the ways that this was actually spreading to try to determine what was causing it. So the way that we found out that physicians were the ones that were spreading disease essentially was back in 1844. This person, Ignaz Semmelweis, was appointed as an assistant lecturer in this Vienna General Hospital. Basically, this is a place where medical students were receiving their training to become physicians. And what he noticed was actually that in his ward, where the medical students were, there's about a 16% mortality rate from this childbed fever. And this was much higher than it was in the second division, where a lot of midwife students were being trained. And there, the mortality rate was only 2%. So they're noticing something's like, okay, what's going on here? So obviously a big difference. The other thing he noticed was that this puerperal fever was actually rare in women who were giving birth prior to arriving at the hospital. So he wanted to investigate and see, okay, well, is there any link here? Is there actually, is this just coincidence, or is there actually something to this? And so basically what Semmelweis noted was that doctors in that first division where he was at, and they had the higher mortality rate, they were performing autopsies each morning on women who had died on that previous day. However, the midwives in their second division, where they had lower mortalities, were not required or allowed to even perform autopsies. So he was able to make that connection between the autopsies and the puerperal fever after one of his colleagues died basically of septicemia after accidentally cutting his hand while performing an autopsy. So they noticed, okay, well, this guy was handling a corpse, cut himself, got infected, and died. Maybe this is something that's being spread to these women who are giving birth. And imagine, especially anyone who's ever gone to the hospital for surgery or anything like that, imagine if your doctor, right before coming into surgery, did not wash his hands and was handling a bunch of corpses from the day before. Also, I imagine refrigeration is probably not super great at this point, so probably room temperature bodies, just great for bacteria to grow on. So obviously, nowadays this seems, painfully obvious, but at the time we just didn't have a good idea about germ theory and the spread of disease. So basically, Semmelweis then started experimenting with various cleaning agents, and then from May 1847, they ordered all doctors and students working in that first division to wash their hands using this chlorinated lime solution before starting any kind of ward work, and then later before they did any kind of vaginal examination. And what they noticed was that the mortality rate, or the rate of this puerperal fever, dropped from 18% down to less than 3% in a very short time frame. And so obviously, at the time they, anytime you find a new scientific discovery, oftentimes it is being treated with skepticism and ridicule. And so even though he was able to say, like, yeah, this looks like it's truly a link here, a lot of people still end up questioning that and said, why wash your hands? That's silly. And obviously we know that to be truly the case now. So kind of examine a few cases where epidemiology has come into play in helping us to kind of shape how we treat patients, or how we investigate disease. But more specifically, what is epidemiology? Basically, it's going to be the study of something that afflicts or affects a population. We're going to be looking at the study of factors that determine not only the occurrence but also the distribution of disease in a population. And there's kind of four main levels of study here. Certainly we can look at the submolecular or molecular level. This is where things like immunology, genetics, biochemistry comes into play. Then you move up into more complex tissue and organ level, and this is where we can see like anatomic pathology. Then we can get up into the level of individual patients, where we can look at individual cases to look at new or novel disease processes and things like that. And then finally up to kind of the most complex level, this level of populations. And this is specifically where epidemiology comes into play, where you can look at many patients, look at many wide range of people, and try to get a sense for what were the things that predisposed them to disease, what were things that are effective in preventing or treating disease, and how can I apply that back to the larger population in order to improve quality of life essentially. Now, with more classical epidemiology, it's much more population oriented, much more observational in nature, where basically you're looking at a community for kind of the origins of health problems. You're looking at things like their nutrition, their environment, their behaviors, to see what predisposes someone to either getting disease or to not getting disease. And oftentimes this is focused a lot on infectious agents. So think about things like tuberculosis, HIV, etc. Now, what we're going to be focusing on more in this class is this clinical epidemiology. And again, what we mentioned with more observational type of studies is that you can't really take a whole lot of cause and effect away from them. You can see, relationships, you can see correlations, but by using things like research designs and utilizing statistical tools, which again, why we looked at the biostat section first, by having those fundamentals, we can start to get an idea of more of a cause and effect sort of relationship. We can start to investigate more in depth, looking at things like improving prevention, looking at things like early detection, and then focusing on diagnosis and treatment of disease to see what's going to be the best for our patients. What is the most likely to prevent disease or to treat it, and make the population healthier as a whole. And again, when we're looking at this sort of thing, we're going to be able to adjust for things like comorbidities. We can look at clinical treatments to get again a better idea of what the actual cause and effect sort of relationships are going to be. So when looking at disease, it's important that we kind of stage it, and we can see that there are different ways we can either prevent or kind of have interventions into preventing hopefully progression or perhaps even curing disease in some cases. But obviously in the earliest stage we have this pre-disease stage, and so this is before the pathology has even really begun. This is where we focus a lot on early interventions that may do things like prevent exposure to an agent. So for instance, looking at lead, how do we get lead out of the homes and prevent exposure to impressionable children, or looking at things like microbes and how we prevent exposure to those in the first place by maybe, I don't know, washing your hands, different things like that. We call this primary prevention, and this is where we're actually preventing the disease process from starting in the first place. Next, you have this latent stage. This is where the disease process has started, but it's still pretty asymptomatic. So you imagine someone who has tuberculosis. They may not be manifesting symptoms of the disease, but certainly they may have a latent kind of infection. This is where we're going to focus more on secondary prevention, where by using appropriate screening and early treatment, you can actually prevent that progression to symptomatic disease. That's why people who are at high risk for developing TB infections, namely healthcare providers, this is why you have to get so many TB tests done, right? Because we want to make sure that if you've had potential exposure, we can hopefully prevent the disease from actually progressing to a symptomatic disease, right? So, or you do things like prophylactic therapy with certain antimicrobials and things like that. And then you have your symptomatic stage. This is where the disease manifestations are pretty evident at this point, and this is where we're going to be focusing more on tertiary prevention. And this is where the intervention is designed to either slow, arrest, or hopefully reverse the progression of disease. But we know, especially with a lot of chronic diseases, diabetes, hypertension, etc., we may not be able to reverse a lot of those effects, but certainly we can slow it down and hopefully extend the life of our patients. So when looking at the mechanism and cause for disease, it's important to not only focus on the biologic mechanism, but also on the social and the environmental mechanisms here as well. So for instance, a good example of this is osteomalacia. And certain women of the Muslim faith practice this practice of purdah, where basically they're wearing burqas and things like that to cover themselves. And so this is can be a social sort of practice that can predispose someone to osteomalacia because of the fact that they are covering the majority of their skin. They end up suffering from a very significant vitamin D deficiency due to lack of sun exposure, and also if they don't have very good dietary intake. Not only that, but you can also end up seeing kind of downstream effects of that because there could be increased maternal and fetal mortality due to the fact they can have distortion of the pelvis due to this osteomalacia. And so you can see how the social factors, nutritional, environmental can all kind of play a role in setting the motion for kind of downstream biochemical or other biologic mechanisms, right? So now we have a baby that's being affected, even though it's something that links back to social practices or religious practices of the mother. So again, it's very complex in a lot of cases, but it's important to kind of take each step in the chain to see how they kind of feed into one another and causing disease. Another good example would be atherogenesis. So again, you have a patient who has several poor social factors in their life, things like excessive fat intake, smoking, or lack of exercise. All of that can contribute to that biological mechanism for developing atherogenesis or developing this kind of atherosclerotic plaques, I should say. Things like having high LDL, VLDL, or low levels of HDL, which we know to be generally protective. Now, social risk factors can have different effects depending on that genetic pattern of each individual. Some people will be more prone to having high LDL or low HDL. And so again, that's another layer where you have to now consider what is the genetic impact that are interacting with the environment and other types of risk factors. So when examining this stuff, basically you try to look for, especially with infectious causes, you look for kind of this triad of factors that cause disease. We'll talk about a fourth one as well, considered to be the vector, but kind of the classic example of this would be malaria, where basically you'll have the host, the agent, the environment, and then finally the vector here. So here we find that the host for malaria is typically human. The agent is this plasmodium. There's 5 different species essentially, but all can cause malaria. The environment, obviously, if you're around things like stagnant water or tropical climates, they tend to be more likely to have as plasmodium species kind of proliferating. And the vector here, the thing that's transmitting the plasmodium, is this Anopheles mosquito. You see how there's this interlink between the host, the environment, the agent, and then the vector kind of helping to spread the agent to the host, and assuming they're in the proper type of environment. So one of the other big important things we focus on, especially with our sample, because again, we are looking at people, we're looking to see what are things that lead them to be more susceptible or less susceptible to disease. And so we call these host factors. And so some examples of this, especially different features of a person's genotype affecting how resistant or susceptible they are to disease. So for instance, like a skin color. If you have darker skin, you typically get less sunburn, maybe you have a lower risk for developing skin cancer. If you have a higher BMI, obesity we know makes you susceptible to many diseases, hypertension, diabetes, etc. Looking at things like the immune system, do you have specific resistances to certain types of cancers or microbial disease? And then finally, social behaviors as well can be really important here. Looking at people who exercise versus those that don't. Does that enhance their resistance to diseases like, the many effects of metabolic syndrome and whatnot? So, a good example of this would be something like measles. We know that this is seldom fatal in well-nourished children, even if they're not have been immunized previously. But if you have someone who has host factors that make them more susceptible to measles, things like malnutrition, you can find a much higher mortality rate in those type of children. And certainly there's a huge variety of agents of disease. Certainly you think a lot about the biologic agents. You think about things like infectious organisms or biologic toxins. But there's many things you probably don't think of as being agents of disease. So for instance, think about chemical agents. One of the big things that certain toxicologists focus on are occupational health. This would be something like, people who work in coal mines. Are they more likely, due to their exposure to coal dust, to certain types of respiratory disease, right? You also think about things like physical agents. You think about possibly radiation exposure or heat or cold or even noise, say the link of noise levels in the workplace to, deafness, and et cetera. And even there could be social or psychological stressors, possibly being agents of disease. Plus or minus, we don't, maybe not sure, but this is why we have ongoing studies that are starting to look at these sort of things. And so, also the environment is going to play a huge role here as well. Because again, depending on the environment, the exposure between host and the agent can vary pretty widely. So if you consider someone eating in a restaurant, if it has poor sanitation in the restaurant, you may be more likely to be exposed to some of these agents of disease, right? Think about poor weather or road conditions, probably more likely to be exposed to car crashes and death related to that. Or crowded living environments. This is a big reason why you see spread of many diseases if you have very kind of close quarters type of living arrangements. Think about things like prisons, think about things like cruise ships and spread of disease there. That can be a big factor playing a role due to the environment. And then we look at the vectors of the disease. Typically, you think about things like insects, animals, arthropods being the reason, or being a vector for disease, spreading it from one to another. But you never think about, or you may not think about certain things as inanimate objects or people being a vector. So consider things like drug dealers. They are spreading. The agent here being things like cocaine or heroin. We have a huge problem with opioids here in the United States right now, especially one of the big ones being heroin that is being laced with fentanyl. Fentanyl being a very potent opioid, much more potent than heroin is by a factor of 1,000 at least. And so you have heroin being laced with fentanyl, maybe unbeknownst to the drug dealers, but when they're selling it to their users, they end up having deaths associated with respiratory depression and apnea. At that point, now you consider the drug dealer the vector for disease. You also think about objects, inanimate objects, things like contaminated needles spreading things like HIV or hepatitis. The key point to note here, though, is that to be an effective transmitter of that disease, the vector usually has a specific relationship to the agent, to the environment, and then also to the host, right? So think about, a drug dealer being in the middle of a, downtown urban area, urban center, where maybe there's a high rate of HIV being spread amongst drug users, things like that. You think about all these different factors, how they all play a role in one another, in leading to disease. So I've mentioned this example previously, but here's a good one that will show you the relationship between the agent, the host, the vector, if they're in the correct environment. So again, here we have the Anopheles mosquito, which is going to be our vector, because again, they're carrying that plasmodium, which will then be transferred into the host, which is obviously the person. The dormant parasites then can activate, and then will spread and cause disease within the person. And then after that, then it can then spread back into the vector again, assuming the mosquito is another one's feeding off of the host there. So one of the things we do to help us determine what the risk factors are for a disease is this Bing's model. And so basically you can see that it will start off with, and we'll look at these more in detail, but the biological factors or behavioral factors can be a risk factor for disease. We'll look at environmental, immunological, nutritional, genetic, and then service, social, spiritual sort of factors, kind of a catch-all there. So looking at biological and behavioral factors, these are risks that may be influenced by things like gender, age, weight, bone density, lifestyle, all these sorts of things can be an issue here when in regards to being at risk for disease. Smoking is a really good example of a behavioral factor. So we know that smoking is seen to be associated with an increased risk for myocardial infarction, different types of cancers, COPD, and what we find is that in the studies we've done, these kind of large epidemiologic studies, that cigarettes are responsible for about 50% of MI or 90% of lung cancer. So responsible may be a too strong a word, but at least been associated with a large number of these cases of lung cancer and MI. Diabetes. This one's tough to debate how many deaths are directly attributable to obesity, but the CDC themselves estimate anywhere between 112 to 400,000 deaths a year related to obesity, and kind of the associated behavioral factors that go along with that. So namely being inactivity and typically their diet. And so this may soon become one of the leading causes of premature death in the U.S. And again, very much related not only back to genetic factors, but also heavily on their behavioral factors as well. We know that multiple behavioral factors can lead to spreads of disease, premature death, injury. So think about things like, what was some of the behavioral factors that led to spread of HIV and AIDS? Well, in some cases, sexual promiscuity can be a big one between unprotected, sexual intercourse. IV drug abusers are another really big high-risk behavior that can lead to spread of disease. Think about things like, drug abuse, obviously overdose. Some cases, even Parkinsonism could be related back to this. Think about excessive intake of alcohol leading to things like pancreatitis, cirrhosis. Driving while intoxicated, obviously that can lead to things like car wrecks and either death of the driver or passengers, or maybe innocent bystander. And obviously things like homicide, suicide. So again, these are all behavioral factors. Again, these are typically ones that are probably the cheapest to change in a lot of people. If you try to address the behavior of a person, it's really hard to change their genetics, but it's pretty easy to tell, to tell someone, hey, don't drink while driving, or don't drink and drive. It's a lot easier behavior to change than, say, for instance, their genetic factors. But, and again, in all these cases, change behavior could prevent untoward outcomes. And so, again, because this is kind of the easiest thing to focus on, this is where a lot of efforts get made into health promotion again. So just making people aware of things, like in Farm, we talked about Ray's syndrome, and that being a risk with aspirin intake in kids with viral illness. As long as you put out a lot of education about that, and you educate parents on the risk of Ray's syndrome, that is something that affects behavior, right? So, okay, now I know about Ray's, now I'm not going to give aspirin to my kid. That leads to less cases of that. So again, these are typically the kind of cheapest and highest yield sort of interventions we make in epidemiology. Obviously, environmental factors are very important here as well. And what you find is when you have new new outbreak of health problems, this is where typically where epidemiologists are kind of the first people to show up in a lot of cases. That may be dispatched by the CDC or other groups. But good examples of some of these environmental factors that lead to, say, new diseases at the time. One of which being in 1976, this American Legion conference in Philadelphia. This is where they were discovering they had this pneumonia epidemic. They couldn't figure out what the reason was, and so they set in these epidemiologists, and they were able to discover Legionella pneumophilia. That's where the name comes from, as I mentioned probably in the Bugs and Drugs lecture. Basically, they were thriving in the air conditioning system, and that's again where we got Legionnaire's disease from this American Legion conference. A good example would be Lyme disease. It was back in this period where we just first discovered, disease being transmitted by ticks. We discovered the bacteria, and then again, that's where now we know about Lyme disease. There can be immunological factors here as well. Smallpox is actually one of the first infectious diseases we ever had that we said was eradicated from the globe. And this was really due to the fact that we had vaccines that prevented disease, and we saw kind of herd immunity develop here. And we'll talk more about herd immunity a little bit later on. But another big thing is looking at immunodeficiencies and how this can lead some patient groups to be more likely to develop certain diseases. So you can look at things like the diseases they have, genetics, malnourishment, chemotherapy, corticosteroids, lots of things that can lead to immunodeficiency, which will again predispose them to certain types of diseases. So nutritional factors can be really important to look at as well when looking at different rates of types of diseases. So for instance, back in the 1950s, they're looking at Japanese Americans who were living in Hawaii, and they just had a much higher rate of MI than people that were, basically aged and sex adjusted or sex controlled. So if you're, looking at people the same age and gender, comparing those people to ones in Japan, they found that people in Hawaii had much higher rates of MI. And so, okay, well, that's weird, but they look in California, the same type of Japanese Americans, they're still higher. So one of the things they'll lead it back to is a lot of these dietary factors. What types of foods are they eating? What is the quality of foods that they're consuming? Is it high in saturated fats? Is it high in high fructose corn syrup? Things like that can predispose people to different types of diseases. There's a physician named Dennis Burkitt. He was also he's an epidemiologist looking at the role of dietary fiber on good health. And it's kind of interesting because basically some of his cross-cultural studies he was looking at had some statements including, by world standards, the entire U.S. population is constipated. Things like appendicitis doesn't occur in Africa unless the patient speaks English, because that kind of implies some, nutritional factors possibly associated with that. African medical students go through 5 years of training without ever seeing any kind of coronary heart disease or appendicitis. And then populations with large stools have small hospitals. Those with small stools have large hospitals. So again, and we see this very frequently, especially in the pediatric ED. A lot of kids come in for abdominal pain, and guess what they normally are diagnosed with? Constipation. Yeah, so it's a big issue. Being dehydrated, relatively speaking, and having low dietary fiber can predispose you to different types of diseases that you may not see a lot in other countries. So some of the diseases which have been seen to be pretty rare due to indigenous populations in tropical Africa, things like different types of cancers, appendicitis, a lot of GI issues. So, it could be related to certain genetic factors, but a lot of it could be related back to diet as well. And these are the links that epidemiologists are trying to look for. So again, the differences in some of the instances of diseases were not primarily genetic when they did the studies, because they found that African American patients in the U.S. experienced the disease rates at similar rates as other groups, as Caucasian groups or Latino groups and things like that. So again, the current heavy burden disease in the U.S. Is not inevitable. When looking at this, just remember to eat your fiber. So of course you can always have your colon blow. That's a pretty good way to get most of your fiber in. Not sure if anyone's seen that SNL skit, but I encourage you to look up a YouTube video if you can. Anywho, moving on, there's certain genetic factors, things like genetic inheritance of certain resistances and also susceptibilities to disease, and many different types of diseases. And so this is one of the big things that we are now looking at, is looking at population genetics and this genetic epidemiology, right? So we're looking for the distribution of normal and abnormal genes in the population and see whether or not these are, what we say, equilibrium. Are there changes in genetic factors over time? Are there certain pressures that are leading to certain genes kind of becoming more prominent or less prominent, et cetera. And so, genetic epidemiology is really concerned with that gene mutation rates, which do not really seem to be changing all that much. So one of the interesting things about the genetic factors here is that we're starting to see that genetic disease is accounting for a higher proportion than it did in the past. And it's not because the incidence is increasing necessarily, but mainly because the incidence of non-inherited disease is decreasing. So for instance, rickets, which can be a genetic disease or can be mainly due to nutritional factors as well, we're starting to see in Quebec they have found an abrupt fall in incidence of the non-inherited disease, and then they started to see an uptick in the heritability of it. Basically what they're seeing is that the fall in incidence occurred after they started doing universal supplementation of dairy milk with calciferol, or it's a form of vitamin D. And so basically what they're seeing is that they're dealing with all these nutritional causes of rickets, which is basically this disorder of calcium and phosphate homeostasis related back to vitamin D deficiency. They're able to deal with all the nutritional factors because they started supplementing it in all the milk, but now all of a sudden the incidence of disease that was there tended to relate it back to the genetic causes. And so again, the higher proportion of it was due to genetic issues than it was due to nutritional factors. And so again, we're seeing this shift as things like certain epidemiologic interventions like supplementing milk is starting to become more common. Nowadays, we're starting to see that genetic screening is becoming more prevalent and becoming more important, because now we can do things like identify certain problems in newborns, things like fetal ketonuria or congenital hypothyroidism. And so this is really important that we're able to identify some of these genetic disorders beforehand, so that way we can actually start to initiate things like genetic counseling. We can start to properly kind of risk stratify patients or start things like preventative therapies and whatnot. We can even do things like determining who may be likely to respond well to a particular drug, for instance, or see if we have patients who may be at more risk for certain types of breast or ovarian cancer or asthma, or different things like that. And so as we get more information about the genetic links between these mutations and disease, we'll be able to see more screening occur here. We can start to see more, certainly right now, some of the things we have is that there can be some ethical concerns. Things like insurance coverage can be a really big problem, especially, for patients with known genetic risk. That can be a big concern. So it's something to consider as we go forward, especially depending on whatever type of, healthcare becomes a law of the land here in the future. Pre-existing conditions is a huge sticking point for a lot of people right now. And what if an insurance company could look at your genes and say, well, we're not going to cover you for this because you're at increased risk for heart disease or whatever happens to be. So this could be a big ethical issue in the future. So moving on to the services, social and spiritual factors. Basically, one of the things we look at with medical care for services is that you think about them being quite beneficial to health, but they also can be dangerous. I probably mentioned before that hospitals are kind of the worst place to get healthy, mainly because of the risk of things like adverse reactions or adverse events that can occur. The Institute of Medicine has done several reports where they look at, the certain death that can be attributed, or certain harm attributed to things like medication errors, wound infections or other types of infections that can be spread amongst people within the hospital. And back in '97, when they did this study, and again, this is now 20 years old, they estimated about 44,000 deaths each year were secondary to some of these medical errors. And I don't know that the results are any better nowadays, but certainly now that we know that there's a problem, that's why a lot of hospitals are doing things to try to prevent these things like, infection control is much, much more important. Medication safety practices are much more prominent, because we're trying to drive these numbers down to make sure that the medical care that we're providing is ultimately trying to help our patients get more healthy rather than become more ill. Then there's also the considering the social and spiritual factors here on how it can affect disease. And so there is, even though it's been less well studied, there's still evidence that accumulates about things like the effects that personal beliefs have on their individual outcomes or their quality of life and things like that. So what is their social network, what is their spiritual relationship, like things like that can affect not only their well-being, their state of mind, but certain other practices can affect their health in other ways as well. Even, one study that was reviewing the literature, they've actually found there's an association between religious faith and generally better health. And again, as we mentioned, as we've seen in biostats, is that you can find one study that shows positive results in one way. You may find other studies that show negative results in another. But again, there could be something to a person's state of mind and their mental well-being and maybe their spiritual health, and seeing that it could be related with better health outcomes. So again. More evidence is being seen with this as more studies are being performed. You can also find certain health-related factors in disease and different types of spiritual faith. So, for example, they were looking at Mormons and Seventh-day Adventists, and basically what they were looking at is that these groups had lower than average age-adjusted death rate. So again, when you factor in age and take that out of the equation, the death rate tend to be a lot lower for different types of common diseases. Heart disease, cancer, respiratory disorders. Looking back, what are the causes of that? Well, could it be that Mormons prohibit use of alcohol and tobacco? That seems like it'd be a pretty good way to lower things like respiratory disorders, and heart disease. And then Seventh-day Adventists, they likewise tend to avoid alcohol, tobacco, and they also encourage a vegetarian diet. So again, all these things may be leading them to, even though these are questions of what faith they follow, but these practices can have ultimate effects on their health in the long run. Another important thing to consider is these kind of ecological issues that come up in epidemiology. And basically, you can't just look at it as a people or a person as just an individual organisms, but they're really kind of members all interacting with one another in this kind of social community. And so it's, the world needs to really understood as kind of a complex ecosystem and how changes in one feature may have kind of downstream effects. Not necessarily like the butterfly effect we're talking about here, but it's important to kind of understand these relationships and how they can differ pretty greatly from one country to another. So what we've seen is with the growth in the world population, which is about 7.4 billion as of 2016, and this kind of rapid technological developments, that has pretty profound effect on our global environment. Oftentimes with kind of deleterious effects for the most part. And so we're seeing is that every action that we're taking, and again, even if our actions are to increase the health and well-being of people, that can have downstream effects that are affecting the ecosystem. And again, this may not always be in a positive sense. And I'll show you a few examples of that in just a few minutes. So this table has a few examples of kind of initial health problems, how we move to solve them, and kind of the unintended consequences that affect kind of the ecology around us, either as people or as kind of the environment goes. And so, for instance, when you're looking at, say, childhood infections, overall, I think most people find that childhood infections are bad, and so we vaccinate against them. It seems like it's a good thing, right? Well, there could be other unintended consequences you don't consider until later on. So, for instance, by people being exposed to vaccines early on, you may find that while they're protected as a child, they lose immunity over time if not given proper boosters and things like that. And so you can end up finding kind of an overall decrease in level of immunity during adulthood. Because again, vaccine are never going to be you'll never get as durable a response from a vaccine as you would if you had actually the true disease in question. But again, a lot of this is due to lack of repeated exposures, because again, if everyone's immunized against a particular disease, that herd immunity prevents it from really ever taking hold, and so a lot of people end up losing that immunity over time potentially. We'll talk more about that in a few minutes, but also looking at things like high infant mortality rate, again, generally a bad thing, and so by improving sanitation, this can help to decrease the infant mortality. So what are the unintended consequences? Well, things like increasing the population growth rate, for, maybe we'll be up to 8 billion before too long because of this increased rate due to higher sanitation, and then certain diseases may be more likely to develop epidemics. And again, we'll talk about these causes in a little bit later, but things like poliomyelitis, hepatitis A, etc. Then things like we had this disease in certain cattle called sleeping sickness that was spread by this vector called the tsetse fly. Well, if you got control of the tsetse fly, then you now have more cows that are alive, and now you start to see things like increasing the area of the land subject to overgrazing, drought, and this can actually lead to increase in cattle population and can change, the ability to, basically change the actual ecosystem there by overgrazing that land. And then looking at things like, malnutrition, need for larger areas of tillable land. Here's where we will do things like construction of large river dams, and that can lead to some big changes in things like the environments available for certain vectors. So you may find that certain infectious diseases become more prominent due to some of these changes in the actual ecology that occur here. So again, even though we're doing things ultimately to benefit people or the animals or something like that, you can ultimately see some unintended consequences, and this is important to consider, especially from the epidemiology standpoint. So, looking at vaccine and patterns of immunity, we see that we have this phenomenon called herd immunity. This is really essential when thinking about some of that ecological problems that I mentioned before. So, if there is no herd immunity against the disease, and basically everyone is susceptible to it, you find that the number of cases essentially will double for every disease generation. I'll show you a graph of this in just a second, but if you have 50% herd immunity against the disease, you'll find that the number of cases typically stays pretty small and remains pretty constant for the most part. And then again with this model, if there's going to be greater than 50% herd immunity, as would be true in say a well-immunized population like the U.S., eventually you would expect the infection will die out eventually. So looking at here in this case, say here we have absence of herd immunity versus the presence of about 50% herd immunity. So here you have the initial case. They have exposed it to 2 people. Again, no cases of immunity here because again there's no vaccines. So again, here's the first disease generation where again it's doubling. Again, because no one has any exposure, you can see it doubles every generation. Is you have again doubling of the number of people exposed and developing disease. On the other hand, if you have this model here where you have the basically 50% herd immunity, you have the original case, they expose it to 2 people. One of them is immune and will not catch the disease. And so this person will catch it though, because again, it's only 50% immunity. Now you see as it goes to the second generation, both these people are going to be negative because one was already immunized against it, but now this person has had no exposure to the disease, so they stay disease free. On the other hand, the one that was exposed and does have disease, they will not spread it to this person because they are vaccinated, as opposed to this person who will get it. So you see here, even with 50% herd immunity, you block a large number of people from ever getting the disease in the first place, right? Ideally, with everyone being immunized, you would basically have the disease die out. Similar to what we saw with smallpox, right? Basically, smallpox is considered eradicated because there's a very successful vaccine program that was put into place. Herd immunity was very large, and so the disease eventually kind of wore out. Now, of course, that model we were looking at was a pretty simplified version, but the degree of immunity really necessary to eliminate a virus kind of depends on several factors. So it depends on the type of virus you're dealing with, depends on the time of year. So again, different viruses may become more prominent during different parts of the year, especially like influenza in the upcoming winter months, and then also looking at kind of the density and the social patterns of the population. And so ideally, you think it's immunization is pretty simple. You just immunize everybody in childhood, and there shouldn't be any problems from the targeted diseases. In reality, we're going to find it's a little bit more complex than that, and we'll talk more about that in a little bit more detail. So diphtheria is a good example of this, where basically there's a vaccine that was produced, immunity in individuals, but it tended to decrease over time. And again, no vaccine is perfect. You tend to find that we talk about the durability of a vaccine and how long you will remain immunized against a particular disease. And so diphtheria is one of those ones where it tended to decrease over time. And back when diphtheria was a more common disease, people who've been vaccinated against it, tend to be exposed more frequently to the causative agent, and this would expose the child and result in kind of a mild reinfection. That reinfection would end up producing kind of this natural booster effect, and that would retain kind of a higher level of immunity essentially. So again, the best form of immunity is if you actually react into the true disease. A vaccine is never going to be as good as the real thing essentially. So as diphtheria became less common due to these immunization programs, you found that fewer people ended up being exposed kind of as their immunity dipped, and so they did not really get any of these kind of little subclinical booster infections, right? So in one case in Russia, they actually found that despite the fact they had kind of a wide availability of the vaccine, many adults, especially those who had not recently been in the military, or I guess they had gotten a booster, or they maybe had been exposed more likely, they were found to be more susceptible to the organism. And then beginning in 1990, they ended up becoming a major epidemic in diphtheria. And what they found is that 72% of these reported cases happened to be in individuals that are older than 14, right? Because kids are getting vaccinated very early in life, but as they started to dip down in immunization, or their immunization status started to dip, and they didn't have these additional kind of like booster exposures, they end up finding overall susceptibility to the disease increased over time, and this is where you get these epidemics popping up. So again, the outbreak was not due to a lack of initial immunization, because they actually found that more than 90% of those adults in Russia had been fully immunized as kids. But the disease in older people apparently was due to a decline in those immunity levels over time, because they just weren't getting those little booster infections. And so before they were able to get under control, they had about 125,000 cases of diphtheria and about 4,000 deaths associated with this. So again, vaccine programs are not end all be all, but there can be unintended consequences of these type of programs. And smallpox is another one where it's kind of worldwide eradication has been met by immunizing people against the disease, but there were some potential risks in the attempted eradication there. So again, the dominant form of smallpox in the 70s was variola minor alastrim, which is a relatively mild form of smallpox. It was often disfiguring, but had a relatively low mortality rate. And so basically this provided individual and herd immunity against the much more kind of disfiguring and often fatal kind of variola major form of the disease. It's kind of the classical smallpox. And so to eliminate alastrim and instead get variola major would have been kind of a poor exchange. And so the smallpox vaccine that we had, fortunately, was effective against both forms of smallpox, and the immunization program was pretty successful in eradicating variola, both minor and major. The polio vaccine is kind of interesting in illustrating the need for herd immunity. So initially when we had a vaccine, it was this inactivated form, this IPV form, and it was available back in the 1950s. And so it was good because it provided protection against the immunized individual, but it did not really help to provide a whole lot of herd immunity. Because again, normally you'd expect herd immunity to make it so that if I was vaccinated against something, I would not be able to spread it to anyone else. What they found is that even though this IPV was able to stimulate production of blood antibodies against the polio virus, it didn't really do anything for cell-mediated immunity in the intestine. So that's where the polio virus could multiply and did not really help to disrupt kind of that viral replication in the intestine and prevent spread. So they found declining rates of this paralytic poliomyelitis that lulled a lot of people back into kind of a lack of concern. They started to find that childhood immunization rates were starting to decrease, and that led to these kind of little periodic small epidemics that formed in the late 1950s, early 60s. Because again, that polio virus is still present. The kids weren't being vaccinated, but people who had been previously vaccinated could still spread it to others. And so that's when they ended up developing this live attenuated oral polio vaccine, is OPV, and that was approved in the 60s, and that helps to provide both cell-mediated immunity and will prevent the polio virus from replicating in the intestine. And so now with this OPV, we have this herd immunity that's available. So after widespread use of the OPV in the US, they saw the prevalence of all three types of this wild polio virus declining pretty rapidly as monitored in like waste sewage, because again, it would replicate in the intestine, so you could check it in the sewage to see if it was still there. Now it seemed to be pretty much eradicated from the Western Hemisphere. The last case that we had of paralytic poliomyelitis was basically confirmed in Peru back in August of 1991. So pretty decent period of time without any kind of cases of this. So it may seem like the OPV was always superior. What's kind of interesting is back in the health department at Gaza Strip, they were only using the OPV and never the IPV. And so basically they end up seeing these cases of paralytic poliomyelitis start to occur in these Arab children. They couldn't figure out what was going on until they started to look at the inadequate sanitation environments that the children were in. And basically they end up having kind of competing intestinal infections that, even though they're being given the OPV, they found that it kind of interfered with the ability for the vaccine to really kind of take hold. And so those children still ended up being at risk and were essentially unprotected. So nowadays, we switch to a program where the children are typically injected first with the IPV, and this produces pretty good adequate blood immunity, and then later on they're given the OPV as kind of a booster, and so that way they are very well protected and they are prevented from spreading it to anyone else. Now we kind of have the best of both worlds. And so again, as far as indigenous cases of paralytic poliomyelitis in the U.S. since 1979, due to the OPV, only one case per 2.4 million vaccine doses. That's pretty good, because again, anytime you're giving a live attenuated vaccine, there's always a risk that it could cause disease, especially in immunocompromised individuals, but really don't see that with this one very often. And so now, since 1999, to eliminate any risk for vaccine-caused diseases, CDC has now opted the infants be given the IPV instead of the OPV. because again, they have kind of poor immune systems. So as they're infants, they can be given the IPV, and they're not really worried about causing actual disease. So the effects of sanitation is kind of interesting on epidemiology because for several reasons, one of which was back in the 19th century. Basically what they found is that diarrheal diseases were one of the biggest killers of children, and that TB was kind of one of the largest killers in adults. And so this kind of kicked off the sanitation revolution, especially in England in the middle of the century. And so this was one of the major factors that helped to reduce a lot of this infant mortality rate. And so because of that, you end up seeing kind of a big explosion in the population growth because of the fact that more of these kids are actually surviving. And so this kind of develops what we call a demographic gap, because now there's a much larger gap between the birth rates and the death rates of the society. And so you see this rapid population growth that occurs here. So it's important to realize this relationship between this infant mortality and kind of this explosion in the population growth, because it goes back to the question of population control. Because obviously people cannot procreate ad infinitum, because otherwise we're going to run out of space for people to exist, and that's already a problem we're starting to face. But what's interesting is when you're looking at these certain places and periods of time, you find that when infant mortality rate's really high, you notice there's kind of a push for people to have very large families, large number of kids, because they need to have a reasonable confidence that at least one or two of them will survive to adulthood. Versus when you're in a period where infant mortality rate are going to be relatively low, that's when you need to start looking at, say, having smaller family sizes and more of a requirement for that kind of population control. I don't know if anyone's ever seen Monty Python and the Meaning of Life. This is a picture from the very funny scene where they sing the song "Every Sperm is Sacred." Basically, they were not using any kind of birth control, and they ended up having like a gazillion kids. But back in the day, like that was a necessary thing because many of them were destined to not make it due to sanitation issues and other things. So the effects of sanitation, especially this revolution in the 19th century, really affected disease patterns in kind of unanticipated ways. And so one example of this would be kind of this appearance of poliomyelitis late in the 19th century. And so what you find is that before the polio vaccine was available, they found these epidemics were starting to form as a nation's sanitation improved. And even though the overall proportion of people who were infected with the polio virus tended to decrease due to improved sanitation, it was also delaying the time to when most infants and children were being exposed to it. And I'll talk about that in just a second here. Basically, most kids who are being exposed to it no longer, because it was later in life that they were exposed to it, polio, basically means that they were no longer being protected by maternal immunity. So before, when sanitation was poor, there's more people, higher proportion of people with polio, but it would be more difficult to spread to these infants because they have maternal immunity essentially, so they were more likely to survive that. Now, with the sanitary revolution, the overall proportion decreased, but these kids are getting hit at a later time frame when they did not have maternal immunity, and thus they're more likely to develop this paralytic form of the disease, right? And so you see these, basically this epidemic paralytic poliomyelitis that would break out as an unwanted side effect of this improved sanitation. And what's interesting is that before the vaccine came about, people who were in the upper socioeconomic groups tended to have the best sanitation, and they tended to be hit even harder than those that were kind of in lower socioeconomic statuses, where they would be more likely to be exposed to it on a regular basis. So vector control can be another way that we can try to stave off disease, and so this is a good example of the unintended side effects of trying to control vectors to try to prevent disease. So in sub-Saharan Africa, basically they're trying to control this African sleeping sickness that affected mostly cattle and then sometimes people, right? And so basically the vector here was a tsetse fly. And so they were trying to control this, and so when they got the fly numbers down, basically the herders were able to keep larger numbers of cattle because they were living for longer, and this actually ended up leading to overgrazing of these plains and whatnot. And so overgrazed areas tend to be subjected to more frequent droughts, and then they end up developing into dust bowls. So here we can see whole ecological changes as a result of these controls for disease. So typically what you see is the epidemiologists, they are going to, by studying the populations, by studying the environment, they're going to be providing kind of initial hypotheses about the disease causation, and this will allow for other scientists to try to test these hypotheses in the laboratory or in clinical studies. And so, over the past 30 years or so, these methods have suggested, kind of a probable type of agent and then the modes of transmission for many diseases. And so it's really important to know about these modes of transmission. And by knowing this and by being able to test these hypotheses out, we can allow for prevention to be developed. So this laboratory work helps us to identify causal agents, can clarify aspects of the pathogenesis, and eventually allows us to develop things like vaccines, treatments for these various diseases, and basically continues on for a lot of years after the basic epidemiologic work is done. I mean, we're still trying to figure out, what a vaccine for the HIV virus is going to be, and a lot of that's still based on what we know about the epidemiology of it. And so, as we have a rapid growth in population, we're going to start to see more increased travel and contact with new areas such as jungles. You can see declining effectiveness of antibiotics and insecticides, many other factors that will encourage development of new diseases, or in some cases we'll actually see a resurgence of older ones. And so this is why it's important to make sure we keep track on these sort of things, why reportable diseases are so important, so we can make sure we're not seeing epidemics of that. And also looking at things like global climate change may extend the range of many diseases or help to create new ranges for ones we have not even anticipated yet. So again, these are all things why it's important to keep doing this kind of research to look for new trends, new changes, so that way we can be better prepared for disease when it occurs. And here are just some examples of some of the more recent diseases that were basically the subject of early hypotheses by these epidemiologists. So things like HIV/AIDS, things like hantavirus, things like mad cow disease, SARS, all these different things. The initial research was done by the epidemiologists looking at these new disease outbreaks, characterizing them, and then developing hypotheses that could be further worked on by these researchers. So again, typically you're going to find that the first identified cases for a new disease are oftentimes fatal or severe because they typically have not been caught or diagnosed appropriately. And so that usually is going to lead observers to conclude that these diseases are always severe. And so as we'll discover, as it becomes more is known about the disease, typically you're going to find that there can be less severe or even asymptomatic cases. But the important thing is to develop kind of a case definition to determine who's most likely to get this disease, what are the symptoms we're looking for, if possible, or other kinds of signs and features. And so what you'll find is that even though, initially you think something like, SARS is the absolute worst thing in the world, what you find is that when you can better characterize who's at risk and who may have already contracted the disease, and kind of be in those early stages, kind of these either latent or kind of preclinical stages, you can find that there's less severe forms of it or even asymptomatic cases that are discovered. And so you'll find that with infectious diseases, asymptomatic infection usually is found either by looking at kind of antibody titers to the organism in clinically well individuals, or if you can culture the organism from them. And then looking at the variation in severity of disease gets referred to as this kind of biological spectrum, otherwise known as the iceberg phenomenon. Basically what we mean about that is when you're initially investigating, say, a new disease that has been discovered, you start off by noticing, the deaths first typically. And, it's obviously just the kind of the tip of the iceberg. As you start to get more kind of overt, kind of obvious clinical illness, where these are actually symptomatic individuals, this is when you're going to start to notice, as you get a better way of detecting disease, these asymptomatic infections, right? So typically there's more people that are actually carrying the disease than you might actually think about. And this is what would be an example of a case of diphtheria outbreak in Alabama in the late 1960s. They discovered 2 deaths. They had 12 people who were had evident disease of diphtheria, and then they were able to identify 32 others who were asymptomatic but still had the infection. Some of the things we can do include randomized trials for preventative measures in the field, and we call these field trials. And these are actually another important phase for looking at things like vaccines before it's being given to the community at large. And you're able to kind of look at this and randomize individuals to determine how effective your intervention is going to be. It doesn't have to be vaccines; could be with lots of different features, whether it be some sort of like new smoking cessation aid or some new diet or anything like that. But basically, after the introduction, or in this example of vaccine, you have to do ongoing surveillance of the disease, and then also things like vaccine side effects. It's really essential you do this to make sure that not only is the person protected from disease that's effective, but you're also looking for the safety of whatever intervention you have to be making. So one example of surveillance was really important was in 1954. They were doing these large-scale field trials for an inactivated polio vaccine. This is the Salk brand IPV, and basically they were confirmed the value and the safety of the vaccine. In 1955, when the polio surveillance program at the CDC, and again, CDC is usually the organization that studies a lot of these diseases, they were actually discovering an outbreak of vaccine-associated polio that ended up being linked back to a different brand of vaccine, essentially, it's Cutter Laboratories. And what they found is that they were doing a slight change from the recommended procedure when they were producing the vaccine. And so instead of it being inactivated, it was actually the live virus. And so we were only able to discover that basically because of the vaccine surveillance program that was able to kind of detect the problem very quickly, and they were able to remove it from the market before it caused any further widespread harm. So again, surveillance is super, super important after initiating one of these new preventative measures. So we're able to have surveillance programs that can detect things like measles outbreaks that occurred in several different time periods. And epidemiologists were basically able to show that much of unexpected disease occurred in college students and others who ended up receiving the measles vaccine basically before 12 months of age without having a later booster dose. So again, they see these outbreaks, they're looking at who got the disease and look to see what were the common features between them, right? So this is kind of one of those kind of case control sort of studies that you could do to look to see like what were the common features here, the risk factors that made someone more likely to get measles. And so what they did as a result of that is they changed the timing of the vaccine basically to where if it was given too early, basically the maternal antibodies against measles ended up persisting in the infants, and so it made that the antigenicity of the vaccine actually ended up being reduced. So by changing the timing of the vaccine when it was given, you're able to make the person immune or have a much more durable response. Essentially, they're able to stay immune for longer. And so that's how we got the current recommendations where basically infants children will get immunized initially at 15 months of age. And they'll get a booster dose before they go into primary school to ensure that they've at least had 2 doses of measles before graduating from high school. That way they can be sure to have much more likely a strong immunity against measles when they get exposed, especially close environments like a college dorm or something. Nowadays, even epidemiologists are able to contribute to things like homeland security by helping to establish new approaches for surveillance for things like potential biochemical terrorist attacks and things like that. So think about anthrax, think about tularemia, different types of biological vectors for disease. One thing to always consider when looking at disease control is not just what the actual size of the current problem is, but looking at the potential for disease to spread to others. The likelihood that it can cause harm, death, and disability, and then looking at the cost to individuals, families, and the community. Unfortunately, what you typically find is that legislatures really only fund the disease to control efforts inappropriately by considering how many actual number of cases they've had. So instead of being more proactive, they're really just being kind of reactionary. A good example of this is in the 1950s. There was a sharp drop in the reported syphilis cases that led to declining support for control of syphilis in the U.S., and then eventually you see a subsequent rebound. And so again, sometimes health funding ends up being influenced when powerful individuals lobby for more money or for research or control efforts for a particular disease or injury. So again, it's not always super rational the way the funding gets provided for a lot of these things. And again, most of the time it's just reactionary to how many diseases have been reported thus far. So one case where people are able to kind of set the priorities more in line with what they were concerned about the future showing was due to some of the early 1980s studies that were being done on potential threat for AIDS. even though we didn't have necessarily the numbers there, and we had a relatively just absolute numbers and cost involved at that time, these people are able to show projection where the spread of it was going to be much more widespread than what it was currently. And so because of that, they're able to kind of funnel more funds over and resources over to the study and control of AIDS. And of course, there's only so many bucks to go around, so you may see that some funding may be funneled from other diseases to focus on whatever is currently at hand. And so due to the special concerns with AIDS, including not only the rapid number of cases increasing during a brief time, but also the high case fatality ratio, the huge kind of medical care and the social costs, and just the transmissibility, and the fact that the known prevention methods were not really being well applied. So because of all of these things, they're able to show that, hey, this is going to be a lot bigger problem than it is now. This is why we need the funding for this kind of research. And so in the 21st century, we've seen smoking having declined, and we have some degree of control over the AIDS, mostly due to a lot of education and changes in behaviors and things like that. And then most recently, kind of the bigger problems are things like caloric intake, sedentary lifestyle, and we're starting to see more rapid increases in things like obesity, type 2 diabetes, and all those other kind of metabolic concerns. So one of the big things we're focusing on here with epidemiology is to apply some of these methods to clinical questions and that help us to kind of improve our clinical medicine. So again, particularly how we diagnose certain types of diseases, what type of therapy we're going to use, and then what that prognosis is for our patients. And so by using these methods, we can help to improve disease diagnosis. For instance, we can learn how to better select diagnostic tests, determination of the best cutoff points for doing a particular test, and then development strategies for use in kind of screening the disease. And so this is one of the big things you'll find a lot of the studies we're going to look at include okay, well, we want to diagnose PE in our patients. What are the best symptoms to use to do that? And that's where things like epidemiologic studies can come into play here. You can also use these methods to determine what is going to be the most effective treatment for our patients. So, for example, we had one randomized controlled trial. They used a lot of different studies around the U.S. to see if methylprednisolone would reduce, it's a glucocorticoid that would reduce spinal cord damage and preserve some of their motor function after they were having a person who had an acute spinal cord injury. And so that was a hypothesis that was actually confirmed, and this is can lead us to we can see the rationale for why we now use methylprednisolone in patients having acute spinal cord injury. Another case where we can use epidemiology to help us improve prognosis. There's a case-controlled method that was used where we're comparing kind of two different coronary prognostic indices. They were analyzing, looking for weaknesses and ways in which that prognostication could be enhanced. And so, again, this is important because if patients, families, they want to know what their chances are with a given disease. What's going to happen to them. And so we need to be able to have studies like this that can tell us, just how well we can evaluate our treatments are going to be, how likely a patient is to survive a period of time, etc. And so this can be very useful for these methods can be useful in developing these kind of studies. This also helps us with risk estimation, and so one of the really good examples of this is called the Framingham Heart Study, where basically they were able to use a huge number of people from Framingham, I believe it was Connecticut, and they were looking at different factors of the patients, including risk for things like cardiovascular disease. They looked at diabetes and all kinds of different things to try to determine what is the risk for cardiovascular death. And so that's where the Framingham Heart Study comes from. Another good example is a Gale model for breast cancer risk. So again, a lot of these studies are very useful for helping us to estimate kind of what risk is our patient at for having a certain outcome. We can also use these epidemiologic methods to help us with planning and evaluating medical care. And so we call this health planning, where basically we use these measures to determine kind of present and future community health needs. And so we can look at things like demographic projections. We can look at the thing like the size of different age groups in the future to determine what kind of care are these people going to need based on an aging population or younger population. And so looking at these patterns of disease frequency, and we can estimate kind of what's the best use of our services, because we're only going to have limited resources. How can we best apply those to things like looking at cost benefit analyses and whatnot to see what's the impact of the medical care that we can provide and how's it going to best serve our communities. So, in summary, epidemiology is this branch of medical science can be relating to what is happening in the life of our individuals and populations. We're looking at these occurrences and distribution of diseases and injuries and whatnot, and we're looking at the all aspects of this. We're looking at the biological, social, behavioral, all these different things, how they're going to be feeding into what causes disease or what is making our patients more likely to experience disease of many types. Basically, we're going to be using these methods to help us to look for patterns in the population. We're going to be developing hypotheses about what we think is causing disease, what we think that method of transmission is, and hopefully what the preventative techniques we can use to try to prevent disease in the first place. Again, we're going to be looking at things like host, the agent, the environment, and sometimes looking at the vector as far as how disease is spread in many ways. And again, does not have to apply just to things like mosquitoes. Can apply mosquitoes and malaria. It can apply to lots of things like spread of HIV with drug use, IV drug abuse, things like that. So always kind of keep these different scenarios in mind. When looking at means to prevent a given disease, we're going to be looking at behavioral, genetic, and immunologic causes for that host. We're going to be looking at the biological and nutritional causes, again, which are oftentimes considered agents here. And just remember that being's acronym. Remember, these are the different factors we're going to be investigating when trying to see, what are the different things maybe we can change, or the things we need to identify as predisposing someone to disease, or hopefully a preventable cause for disease in some cases. Where we're concerned as far as epidemiology goes about human ecology and kind of the impact that these health interventions we're having for people on what it's going to do to the environment. We're going to cause a population boom that's going to cause our resources to be more strained. Perhaps moving to Mars is going to look a little bit better as the future goes on, assuming Elon Musk gets SpaceX in order, right? But again, knowing the solution to one problem oftentimes tends to create new problems, and so that's where kind of continuing evaluation and surveillance by the epidemiologist is so important. Again, looking at different things that epidemiologists have been able to contribute to in the past, different ways to improve disease diagnosis, treatment, better ways for surveillance. All of these things are super imperative that epidemiologists contribute to helping us to better take care of our individual patients. All right, so that's it for the introduction to the epidemiology section. Next, we'll hit the ground running with some more kind of concrete methods for utilizing these techniques and how it's going to apply back to our evaluation of the literature. Thanks, and I'll see you next time.